Good morning, good afternoon, and good evening again, colleagues. This is Botai from Pretoria, South Africa, and welcome back to the third and final session of engagement around the topic of environmental factors in the COVID-19 pandemic. Thank you all for joining us again today. Yesterday was a very intense day with wonderful inputs and interventions, as usual. We have very little time to address all of them fully and adequately. Yesterday, we had two keynote addresses. The first from Dr. Thompson from Wellcome Trust, who provided a set of broad range insights and some important notional and conceptual framing of our question based on her vast experience. Dr. Thompson showed us where we need to focus to reach a sufficient level of understanding of the climate-sensitive aspects of COVID-19. In her address, Dr. Thompson pointed to how lessons learned during the integration of climate and non-climate information with malaria management are relevant in the case of COVID-19. She stressed that while there are excellent tools for seasonal climate forecasting, these tools have inherent spatial and temporal limitations. Dr. Thompson advised that appropriate consideration using integrated disease models at the requisite level ought to be made. She also spoke about how multiple health and other environmental stresses act together to exacerbate situations and how these need to be considered in concert. That is, along which the climate impact elements fell. Drawing from a peer-reviewed scientific paper that was published on Monday by my colleagues from South Africa, the lead author, Professor A.J. Smith, presented the contents of the review paper, which covered substantial literature on COVID-19 up to mid-July. Professor A.J. Smith pointed out that the reviewed work widely varied in several aspects or respects, that is in terms of the dependent variables, independent variables, timescales, spatial scales, analytical approaches that have all been used. Many of these studies had not accounted for compounding variables, the lags in cases data, and also the non-pharmaceutical interventions that could have affected the infection rates. One of the biggest challenges identified is that there is a large amount of studies now on preprint servers, and many of these are potentially, and their methodologies are satisfactorily or flawed, which in fact, very few comprehensive peer-reviewed papers on the topic are available. This is identified as a serious problem from a scientific methods integrity point of view, they are alluded to. Professor A.J. Smith pointed out also that the review was actually really conducted from a Southern Hemisphere perspective with the aim of extracting information relevant to the regional epidemics. Unfortunately, the authors averred that most of the studies published to date are from the Northern Hemisphere. The conclusion of the review was that there is generally contradictory evidence for and against the sensitivity of SARS-CoV-2 and also COVID-19 to the environmental drivers, that is space for time substitutions have strengths and weaknesses, and it's necessary to get better data and perform more robust analysis to really answer this question definitely. We also had a lively panel and Zoom chats yesterday, starting with Dr. Jeff Sherman, who spoke about why it's necessary to answer our key question. Drawing on his experience with other seasonal respiratory diseases and focused on the role of meteorological variables on aerosol droplets, especially the non-endemic coronal viruses, and noted that this virus may well become endemic and be seasonal. But of course, we need to wait and see. Dr. Rachel Baker spoke about the climate change scale of the question, but noted obviously that with COVID, we don't have the data. She explained that from a modeling experimental perspective, there's little change in potential infectiousness of the disease over climate change timescales. that is approximately above 10-year scale. Yet she also cautioned that this remains an important consideration, especially beyond the epidemic phase. Prof. William Pan concurred with the opinion of Dr. Baker that the scientific community have a serious challenge with so little data at this stage. Therefore, Prof. Pan remarked that much untested literature that ends up as a headline news needed to be balanced with a real and urgent need for information on the topic. So he said that this puts us, that is the scientific community, in a very serious predicament and can result in the science being responsible for people dying. Finally, my colleague from Professor Francois Engelbrecht, speaking on the assumption of a demonstrable relationship between environmental factors and COVID-19, which we cannot yet show, but cannot discount, alluded to the fact that we need to prepare for that eventuality and explore what this could do to the disease trajectory, especially in the form of seasonally driven second wave. And of course, there was, from his peers, the panel peers, there was a contestation on what is the definition of second wave. So he also suggested some means of addressing this key question in their paper that they have produced and is in preprint. All these presentations can be viewed on the AGU Facebook page. There are some alterations in today's program, which we will announce shortly. Today, the theme is on action that can be taken. We will have keynote addresses, a panel discussion, a breakout group session, and then wrap-up session. Again, this will be moderated by my colleagues on the steering committee. Now I'll pass on this drone to Dr. Ken Takahashi, who is from Peru, to moderate the keynote session. Thank you all, and see you at the next conference, hopefully in South Africa. Thank you.
Thank you, Joel. Greetings to everybody, and welcome to day 3 of the symposium. I am Dr. Ken Takahashi, and I'll be host for this session. I'm a climate scientist, and I'm also the director of the National Meteorological and Hydrological Service of Peru, Senamhi. And under the auspices of the World Meteorological Organization, my organization and our peers around the world are promoting the development of science for services, particularly in support of tailored services for different users and applications. For instance, food security, energy, disaster risk reduction, water, and health. This in turn requires working closely with the user community. COVID-19 provides an unprecedented necessity and opportunity to dynamizing the joint work between the meteorological and health science communities to establish such services and make this information useful to decision makers and our societies in general. So in this final day of the symposium, we turn to issues of communicating risk and generating actionable information. We have 2 keynotes in this session, after which questions will be moderated by my colleague, Dr. Andy Morse, Professor of Climate Impact at the University of Liverpool. Please type your questions into the Zoom chat window, indicating to whom they are addressed, please. And we will work to get to those during the question and answer section at the end of the 2 talks. Well, now I will introduce our first keynote speaker, Dr. Tiantian Li. Dr. Li is a professor at the National Institute of Environmental Health of the Chinese Center for Disease Control and Prevention. She is also the head of the Department of Environmental Health Risk Assessment in the National Institute of Environmental Health. Her main research focuses on climate change, air pollution, and health, for which she has conducted several major national level epidemiological studies and health risk projection modeling studies based in China. Let's now hear Dr. Li's presentation.
Hello, everyone. Thank you for inviting me to participate in this very important symposium. Today, I'm going to give a talk on climate change, air pollution, and COVID-19. I'm going to introduce existing study evidence in China and share some thoughts on challenges in this field and actions to reduce the health risks. First, I will give a very brief background introduction. The human living environment has been changing and has caused the great burden of disease in the world. In the past 100 years, the world average temperature increased about 0.8 degrees. By the end of this century, the temperature is projected to continue increasing. The air pollution, especially PM2.5 concentration in the developing countries, is still very high. For example, in China, more than 17% of population exposed to the concentration above WHO interim target 1, which is 35 microgram per cubic meter. According to the recent WHO report, air pollution and climate change ranked the number 1 of 10 threats to global health in 2019. Air pollution and climate change are closely linked. The very human activities that affect the Earth's climate also produce air pollutants. The sectors that produce the vast majority of greenhouse gases, such as energy, transport, industry, agriculture, waste management, and land use, are also the main sources of PM2.5 and other key air pollutants. These include short-lived climate pollutants, such as black carbon and ground-level ozone, that also threatens human health. Climate change has direct and indirect impacts on human health and bring great disease burden to the human beings. This figure shows the potential full working time loss in 2018. According to the Lancet cut-down report, about 130 million potential work hours were lost globally due to the heat in 2018, which is 15% more than the baseline year, 2020. In addition to climate change, air pollution also increases mortality and mobility risk, bringing great disease burden to the human beings. These two figures show premature deaths and reduced human life expectancy globally. According to the GBD 2017 report, PM2.5 caused about 7 million premature deaths to the world annually, and PM2.5 also reduced human life expectancy. For example, the ambient PM2.5 reduced 1.3 year life expectancy for the Chinese and 1.5 year for the Indians. A WHO report in 2018 estimated between 2013 and 2015, climate change is expected to cause approximately 215,000 additional deaths per year from four climate sensitivity diseases: malnutrition, malaria, diarrhea, and heat stress. The climate and environmental factors and extreme events may affect the modes of transmission of infectious diseases. Numerous studies already provide evidence linked the climate change with infectious diseases. However, for the emerging infectious diseases such as COVID-19, there's still very limited evidence. Therefore, we still have lots of knowledge gaps between the air pollution, climate change, and COVID-19. The first very important question is how meteorological and air pollution influence the COVID-19 pandemic. That is, to link the meteorological and air pollution with the COVID-19, we need more evidence. The second is how the COVID-19 pandemic in turn impacts the climate and air quality. As we all know, during the pandemic period, many things have changed, such as the human activities, the emissions. So, how this in turn impacts the climate and air quality? We need to know. And the third one is, under future climate change, how will these factors influence the future COVID-19 pandemic and other potential diseases? And what kind of actions need to be taken? Next, I will introduce some existing study evidence in China, which may provide some clues to help us solve the above questions. First, we review the studies related to meteorological factors and COVID-19 in China. There are about 20 studies. Most of them published in the peer-reviewed journals, some published on the preprint website. These studies most focused on the temperature and related metrics, humidity, and other meteorological factors. I will introduce some case studies. The first one investigated the meteorological factors, including temperature, absolute humidity, diurnal temperature range, and confirmed cases in 30 provincial capitals except for Wuhan. The study period is from January to March. And the GLM model was used to explore the linear relationship between the factors and the confirmed cases. From left, the three figures show the main findings of this study, which is per 1 degree increase in AT and DTR, 1 gram per cubic meter increase in AH was related to the decline of daily confirmed cases. This study also found that all these associations increased with accumulated time duration up to 14 days. In summary, meteorological factors play an independent role in COVID-19 transmission after controlling population migration. Local weather conditions with low temperatures, mild durational temperature range, and low humidity likely favor the transmission. The second study investigated ambient temperature and confirmed cases in about 120 cities in China from January to February. The confirmed cases are larger than the first study. A similar statistical method was used in this study. The difference is that this study tried to explore the curve relationship. From these three figures, we can see that the relationship between the ambient temperature and the confirmed cases was nonlinear curve from lag 0 to 7 days to lag 0 to 21 days. The curve was approximately linear in the range below 3 degrees and became flat above 3 degrees. This study also found that there is no evidence supporting that case counts of COVID-19 could decline when the weather becomes warmer. The third study investigated the temperature and confirmed cases in 31 provincial level regions in China from January to February. They first showed the result of the linear relationship, and they found similar results with the first study, which is the negative relationship between temperature and confirmed cases. They further tried the curve analysis for Hubei province and Wuhan city. Both curves had a peak risk at 8 to 10 degrees. They also found that the incidence was more likely to decrease with temperature increase over 8 to 10 degrees. The next study investigated the daily death numbers with meteorological factors in Wuhan from January to February. They found the significant decreased COVID-19 death count with increase in temperature and absolute humidity in lag 3 and lag 5 days, with the greatest effect in lag 3 days. They also found the significant positive association between DTR and COVID-19 death count in lag 3. In summary, the most studied factors are temperature and humidity. Generally, there is a certain contradiction in the existing evidence, and the relationship between meteorological factors and COVID-19 is still uncertainty. From the existing evidence, there may be a curved relationship between meteorological factors and COVID-19, just as a temperature effect on mortality and mobility. There is a different relationship between heat and cold part of the temperature for the mortality and the morbidity. So the further study is needed. Most studies believe that low temperatures may increase. They think low temperature may reduce resistance to respiratory diseases. Virus is more stable at low temperature. We also review the studies related to air pollution and COVID-19. There are more than 10 studies in China, including PM2.5, ozone, AQI, and other pollutants. The first study investigated the long-term exposure of PM2.5 and NO2 with COVID-19 confirmed cases in more than 300 cities in China, except for Wuhan. The exposure is the annual average of air pollutants from 2015 to 2020. During the pandemic period, the PM2.5 and NO2 concentrations decreased compared with the same period in 2019, and this study found that an increase of 10 microgram per cubic meter in NO2 or PM2.5 associated with about 22% or 15% increase in infection risk of COVID-19. The next study investigated the short-term exposure of PM2.5 with COVID-19 confirmed cases in more than 100 Chinese cities. They found a positive increase in PM2.5, PM10, NO2, ozone, and CO concentration was associated with the increase in the daily counts of COVID-19 confirmed cases. However, SO2 was negatively associated with COVID-19 confirmed cases. The third study focused on the case fatality rate of COVID-19 and included 49 Chinese cities. The exposure is the medium-term exposure, which is the average of concentration of PM2.5 and PM10 from January to March. This study showed for every 10 microgram per cubic meter increase in PM2.5 and PM10 concentration, the COVID-19 case fatality rate increased by 0.22% and 0.26% respectively. This study is focused on the ozone exposure in R0, which includes 152 Chinese cities. Interestingly, this study found R0 was negatively associated with 1 hour maximum ozone concentration. Exposure to ambient ozone may trigger slight allergic reaction to human, which could enhance pulmonary innate immunity. However, this result is not consistent with the second study. In summary, there is a positive association between long-term or short-term PM2.5 and COVID-19, and the long-term exposure effects may be greater than the short-term effect. The possible mechanism is that PM2.5 may reduce lung function and aggregate inflammatory cells, leading to increased vulnerability. The relationship between ozone and COVID-19 is contradictory in the current evidence, and more study is needed. Last, I'm going to share some of my thoughts of the challenges in this field and proposed actions for climate change, air pollution, and COVID-19. There are lots of studies that provide evidence on air pollution, climate change, and human health. Of course, the COVID-19 may affect the human health. Some studies show that the air pollutants and meteorological factors may have some link with COVID-19, but we still need more study evidence. During the COVID-19 pandemic period, there were lots of lockdown actions. Some studies report that the PM, CO, SO2, NO2 concentration is decreasing and may bring some health benefit. Some studies also reported that ozone is increasing during this period, so how about its health risk? CO2 is also decreasing during the pandemic, which may bring the short-term change of the climate. And how about the human health risk of the short-term changes? As we all know, during the pandemic period, there are lots of extreme events in the world. How about this compound health risk? Last, combined with other changes, the socio-economic is also changed during this period. All these changes may bring the long-term effect for our climate change, and we also need to know the related health risk. So the first challenge we may face is the short or middle-term health risks related to climate or environmental factors during the COVID-19 pandemic. The human activities and energy use decreased a lot during this period. However, the changing of the health risk of the COVID-19 pandemic following by the rapid changes of human activities and climate remain unclear. For example, we observed the improved air quality in China for most of the air pollutants, and this study estimates the health benefit caused by the air pollution reduction during the COVID-19 outbreak period in China. The estimated about more than 10,000 avoided deaths. But some studies report that the ozone concentration is increasing during the pandemic period. Ozone may also bring the health risks. Therefore, the short-term effect on climate or the environmental factors and related health risk is a very complex question. During the pandemic, extreme weather events continued throughout the world. For example, in China, we have experienced heatwave events, flood disaster events. The COVID-19 have brought lots of socio-economic problems and made the vulnerable population more vulnerable. How to coping this compound health risk is also a big challenge. The last challenge is unknown long-term health impacts of climate change in post-COVID-19 pandemic. The CO2 emission decreased during the period, and combined with other social-economic changes, we need to understand the influence of climate change related to these changes, health risks related to climate change, and also COVID-19 pandemic risk related to climate change. For coping all these health risks, we need to act as soon as possible. First, we need to clearly understand the relationship between climate change, air pollution, and COVID-19 and other diseases. We need more evidence. The relationship is still unclear, and more study is needed. This is also the basic information for other actions. For the compound health risk, based on the relationship between climate change, air pollution, and COVID-19, we may establish the climate-related early warning system for health risks and prepare the emergency plan. Last, for establishing the long-term response mechanisms, the climate change-related human health risk, especially the COVID-19 health risk projection, is highly needed for supporting the long-term planning for coping the health risks. That's all for my talk, and thank you for your attention.
Well, thank you, Dr. Li, for her presentation. It's been very interesting. We'll discuss this at the end of the next talk. Our second keynote presentation is from Dr. Judy Omumbo of the African Academy of Sciences. Dr. Omumbo has over 20 years of experience in epidemiology, focusing on research to support malaria control programs, where she focused on developing effective partnerships between researchers and vector-borne disease control programs, emphasizing the use of national data, research, and health information systems for monitoring and evaluation. She has played a major role in building the capacity of national control programs through curriculum development. We'll hear Dr. Omumbo's presentation now.
Given the challenges for preparedness for infectious disease control in the African context, and the paucity of data and studies to guide the response to COVID-19, Africa needs to have locally defined priorities in its management of the pandemic. In this presentation, I'm sharing the experiences of the African Academy of Sciences in using the wisdom of crowds to collate regional expert opinion and define priorities for research on COVID-19. Briefly, the African Academy of Sciences is a Pan-African learned society of some of the continent's best researchers in all areas of science. The Academy implements various programs in these 5 critical priority areas, with an overall sustainable development agenda and a vision to transform the lives of African people through the practice of best science. An ongoing and major program of work is priority setting in several areas, including maternal, neonatal, and child health, climate change, genomics, epidemic preparedness, and the work on COVID falls here, with plans to set priorities for the listed additional areas in the near future. That's data and biospecimen governance, 4th Industrial Revolution, mental health, food, and nutrition security. Africa's COVID response must consider our unique economic and social-political context. There's a high disease burden, and many diseases are in epidemiological transition. 20% of the global disease burden, mostly infectious diseases, is in Africa. And we're really expected to have a different comorbidity profile. There's widespread food insecurity, high levels of poverty, and climate and societal change, the impacts of which this audience is very aware. The priority setting program is engaging African and global scientists, policymakers, funders, and other relevant stakeholders in responding to Africa's greatest challenges, which now, of course, include the continent's response to the COVID pandemic. Just to outline the process followed to address COVID-19. We began with a webinar earlier this year in March, followed by an open online survey sent to supplement the priorities listed in the WHO Global Research Roadmap. Over 800 responses were received, and 17 additional Africa-specific priorities were identified. The report from this is available on our AAS website. We are now developing a database of researchers working on COVID through another program, the AAS Clinical Trials Community Program. The last stage of this process was to mobilize our partners to fund a call for research on the priorities identified. This call is a rolling call, and we've had several very good applications for that. Some of the priority areas are listed here. Importantly for us are the additional Africa-specific priorities that have emerged from this process, including defining high-risk groups in our contexts and protocols for managing disease where intensive care is lacking. The priorities have also been ranked, and 59 of them are listed under WHO Global Research Goals. We recognize that these priorities might change with time and changes in knowledge, so this information will be updated in an ongoing process. So this priority setting process was highly successful, and at the request of DFID, we've used the same method to look at the economic impacts of COVID, working closely with the Africa CDC and in partnership with DFID through their East Africa Research Fund. We have developed an update on R&D goals for COVID. These are priorities identified for candidate vaccine research R&D. Again, this report is available on the AAS website. And quite a long list of additional priorities have been proposed from the over 400 respondents. Going forward, we have a rolling call for COVID research as funds become available, and formal engagements with various stakeholders in policy and epidemic response communities. Of importance is our work on mapping expertise in clinical trials across Africa that includes a COVID-19 database and helps to assess the capacity to deliver on a COVID response. This Clinical Trials Community Program, CTC, aims to expedite the process of developing an Africa-led approach to clinical trials, which will also be important for COVID. We have conducted a rapid review of physical distancing as a preventive measure for COVID in Africa, based from the survey I mentioned earlier, and a literature review that has provided some useful baseline data on measures that countries have implemented. Findings are, for example, that stringent physical distancing measures that are not adapted to Africa's context can have negative social, economic, and health impacts. Also, there have been quite a few adaptations of physical distancing that countries have implemented, which do consider the local context. For example, imposing risk-based rather than blanket movement restrictions for temporal distancing. Finally, we have a program that allows grant-making and receiving organizations, whether large or even CBOs, to assess their compliance to a global grant standard. This is a gold standard assessment of their capability to receive and manage grants that assists grant makers or potential funders to disperse funds quickly, as these organizations would have the pre-certification assessments already available online. So I hope that this gives you all a look into some of the activities that are ongoing in Africa's response to COVID. There is a lot of scope to include studies that are looking at possible climatological and environmental drivers of COVID, including how climate and the environment impact contextual factors in COVID transmission. The discussions of this meeting will contribute greatly to the understanding here. I wish to thank my colleagues, Dr. Moses Alobo and Professor Kevin Marsh, who are leading this work at the Academy and have kindly provided the slides for this presentation. Thank you.
Thank you, Dr. Omumbo, for your very interesting talk, and also Dr. Li for her also very interesting talks. This is now the time of the session in which we address questions in the chat. Before that, I would like to make a couple of comments on the talks so far. One is that from Professor Li's talk, the idea of having multiple pathways by which the environmental factors we're addressing here could make their way to impact the population. Something that as specialized communities, like in my case, meteorological climate communities, we might not have totally identified, and we could have a very narrow view of what is needed. So if we're not aware of all these different pathways by which our variables could affect the disease, even the well-being of people, our information might not be as complete as we would like to, and particularly thinking about this framework for climate services that WMO is promoting. And similarly, from Professor Omumbo's talk, the idea of that was followed through in Africa right from the beginning, of making sure we have a large collaboration, a large number of needs being put forward by the actors to make sure we have the right priorities for research. It's something that's a lesson that we should be applying to every country. We're trying to do something like that with this meeting, but still, it's probably not going to be as large scope as what Africa did at the moment. So I think this is a very important aspect that we should always take into account to make sure that what we're doing is not just isolated, but it's all moving forward towards a common goal. So, okay, so with that, I'll now give the floor to my colleague, Dr. Andy Morse, so he can lead the question and answer section of this session. Andy?
Great, thanks, Ken, and thanks for those two really interesting talks. There are quite a lot of questions coming through. I'll try and summarize them. So, Dr. Li, are you on the line?
Yeah, I'm online. Can you hear me?
Yeah, I can hear and see you. Thanks very much.
Okay.
So there were questions coming out on themes, and one of them was very much around the area of comorbidities and whether the climate is affecting the comorbidity as much as affecting the COVID-19. Do you have any information about the comorbidities of those cases that you use in your analysis?
Sorry, can you repeat? I didn't hear you very clearly. Sorry, could you repeat?
Okay, the question's coming out because many of the people that die from COVID-19 already have other diseases, particularly respiratory or other circulatory diseases. In the data, when you analyze the data, do you know about the health status?
Okay, I see. I see
the data that you're using.
Yeah,
This
is a good point.
Comment, yes, I'll let you. I mean, that comment came out in across several questions in different ways. Yeah,
that's a good point. So I think this for the infectious diseases, especially for the COVID-19, we need to carefully control the confounders. And especially we did not use the list confounders in the previous air pollution, meteorological factors with mortality or mobility. So when they try to establish the relationship between the meteorological or environmental factors with COVID-19 incidence or mortality, we should make sure that the potential confounders are well controlled. But for the studies I reviewed, I noticed that maybe some studies didn't control very well. For example, the hospital admission status, policy related to the social distance or the personal protection, the number of people migrating from the pandemic or outbreak area, and so on. So we need to collect all this information and control in the model. But latest challenge, of course, some traditional factors we may use the information from the statistical book, but some new information, we may consider some new method, like using the digital map or mobile phone information from this kind of company. Yeah, compared with traditional studies, I think we need more innovative method. Yeah, this is my answer. Yeah.
Okay, thank you. Another area that came out, and I think you addressed it more maybe in the air pollution than the climate talk, but that's the dealing with the lag when people are infected and before they really get ill. And we know that has a variable number of days. Some people never getting very ill. So you tend to have, so in any study like this, you tend to have statistics on the very ill people because they've gone to hospital. Did you think about how you might put into place the lag with the climate, because they're infected with the weather? They're infected several days, maybe weeks, maybe 2 weeks before they end up in hospital. So I was wondering how much you'd looked at on the lag with the weather.
Yeah, I see. This is also a good question. And I noticed there is a question, see that climate change is a long-term effect and maybe we should consider the seasonal variation, something like this, or weeks. Because I introduced most of the studies day-to-day variation. I think there is a definition of the climate change. Climate change, of course, is a long-term effect. It means the decades variation. Even we see the seasonal or several weeks lags variation related to the COVID-19. It's not the meaning of the climate change from my point of view. But however, it's important to understand the relationship for the short-term effect, middle-term effect, or the long-term effect of the meteorological or air pollution with COVID-19. Because using this information, we can predict or project risk under the changing climate, or maybe use this information to establish the early warning system. So this is my answer. Yeah.
Okay, thank you. I will come back to you. Unfortunately, Dr. Omumbo can't be here at the moment, but I would like to make maybe a little bit of a political comment on her talk, which was a very good, well-structured talk. And she talked a lot, or several times, I think, about the role of DFID, which is the UK Department for International Development. And it has just been abolished by our government. And I think, some of the things that Judy was saying was showing how important the structural inputs and the funding, particularly from some of the government agencies in the global north, have been very important to developing these projects. And unfortunately, they are at the political whim of our leaders. And it's a great shame. I think most of us in Britain, that thinking people in Britain at least, are very worried about the demise of DFID and how that might impact on particularly some of the organizational areas that Judy pulled out in her talk. Okay, so Dr. Li, can I carry on with some questions? Is that okay?
Yeah, okay. Yeah, if I can answer, yeah. I'm very happy, yeah.
So I was going to ask a question, and you said that many of the studies contain temperature in their analysis, and you sort of developed this idea elsewhere in your talk. But why do you think temperature is so important? Is it more controlling the social interaction of people, or is it doing something fundamentally with the ability to transmit, and even not only transmit, but become infectious with the virus? The 3 degree cutoff, is there something culturally in China where 3 degrees is important? So those sort of questions around why do you think temperature is so important, and which part of the whole disease transmission cycle do you think temperature is affecting?
Okay, so because we are talking about climate change, but the temperature is so important for the climate change. So under the background of the climate change, we need to understand the relationship between the temperature and COVID-19, right? But from the Chinese study, we cannot see that there is some certain relationship between the temperature with the COVID-19. We still need more information to answer this question. But it looks like the low temperature, maybe increase the COVID-19 infections. It looks like this, but I think it could be the curve relationship. But we still need more study from all over the world to answer the question.
Do you think that's particularly changing social interactions at these lower temperatures, that people are staying inside and more?
Definitely. So we need more information as always is like a confounder. So we need collect more information and control in our model so that we can understand the true relationship between the temperature with the COVID-19.
Certainly, going away from temperature, certainly absolute humidity is implicated, or more than implicated, in other diseases which get in through the respiratory tract. I worked for a while on meningococcal meningitis with Madeline Thompson that spoke yesterday, and there it's very much implicated that it's the very dry conditions make the invasion here for bacterial, not virus, of course, with meningococcal meningitis, but it makes allows the bacteria to invade much more easily. So I think that interplay between how much moisture is in the air, or in fact going into your lungs, and temperature is quite important. And one thing we haven't talked about at all, and I think we're probably running out of time, is we haven't talked at all about aerosol transmission, and how aerosol transmission may be affected by both temperature and humidity. I don't know, do you have any comments on how temperature and humidity might affect transmission on the street or outside the house in terms of aerosol?
This is this is actually the question related to the mechanism of how temperature affects the COVID-19, or how the air pollution or PM2.5 affect the COVID-19. But from the study evidence, most studies think that the temperature may reduce the resistance to the respiratory diseases, or increase the vulnerability of the population. So PM2.5 is the same. So it's no direct evidence between the temperature, like in fact the transmission. It's just makes the population more vulnerable. So this is a potential mechanism till now, but we still need more study to understand.
Okay, well, thank you very much, and thank you for answering so many questions at the end of your session. But it was really, really good to get some discussion going. I'd like to thank people from the floor for their questions that very much fed into this session. And I hand back now to Ken. Thank you, and bye-bye.
Well, thank you, Andy. I don't think my camera is on. But anyway, so thank you. I thank the speakers. I thank Andy also for taking charge of the questions. Unfortunately, the time has run out, so we cannot answer all the questions you've asked. We'll take note of them and see if we can get them answered later. Now, we have well, first of all, this session is finished, but we have a panel 5 minutes from now, which is also going to be focused on communicating risk and providing actionable information. So this is going to be a very interesting discussion. Please stick with us, but for now we have a 5-minute break. And so you can, as it says there, stretch your legs, grab a beverage, and we'll be here 5 minutes from now. Thank you. Bye.
The conference will begin again in approximately 2 minutes. In approximately 2 minutes, the conference will begin again.
So hello, everyone. Welcome back to the panel session. And I'm a chair professor of Xiamen University and also a distinguished professor of Chinese Academy of Sciences. I'm an environmental ecologist. So I'm pleased to join the science committee and also chair this panel session. Today we have 4 distinguished panelists. I don't want to spend much time introducing them. I know that you probably know them here. They have the list of these panelists. We have first one, Dr. Brahma Cohen, who is an associate professor and a lecturer of public health at the University of Penaforo and Kudi Valley of Congo and Cote d'Ivoire. And he is research interest including water, sanitation, hygiene, and associated health risk, as well as climate change adaptation. Dr. Nitish Dogra is a physician, physiologist, and public health specialist. He is an associate professor at the International Institute of Health Management and Research, New Delhi, India. And we have Dr. Robert Branham. He's the chair of climate service integration in Air Force, United States. And he leads integration of global climate and environmental impact into United States Department of Defense policy, strategy, and resource adaptation plans. And we also have Professor Lucilla Bloomberg. She's Deputy Director of the National Institute for Communicable Disease and also a head of Public Health Surveillance and Response Division in South Africa. And so please join us to welcome them and to be the panelists. And today, I will would like to invite them each 5 minutes and opening remarks and followed up by questions. I also remind all the attendees to type your questions to the Q&A box on your screen, and the questions will be addressed by the panelists. If the question cannot be addressed and by the panelists, it will be entered to the AGU connection discussion side, so we can still continue to exchange the ideas after the session. So now I would like to give the floor to Dr. Brahma Cohen. Please.
Yang Long, Brahma Kone is coming into the meeting, but he's not quite ready yet. May we start with a second panelist, please?
Oh, what about Professor Lucilla Bloomberg?
Yes, I'm ready.
Good.
Yes,
Thank
I'm
you.
here. Yes, thank you very much. So I don't have any slides, it's just a presentation. There we go. So good
That's
afternoon. Yeah, good afternoon, everybody, and thank you very much for this invitation. I'm sitting in the eye of the COVID storm at the bottom of Africa, in South Africa. People were wondering what would happen when COVID arrived in Africa. Well, I can tell you it's incredibly busy. South Africa has more than 60% of the cases in Africa, more than 520,000 of the 830,000 confirmed cases. The outbreak has been a little different in different parts of the country. But if you look at the determinants of that, it may not be climate driven. So it started in the Western Cape. And the Western Cape has probably reached its plateau. And it started there, was introduced by tourists who came into the country in various parts. It started in South Africa in the end of March, peaked in the Western Cape first, probably because of multiple introductions from various sources rather than climate driven. It's moved into other parts of the country, into the more inner, into the plateau areas, the higher altitude areas. Johannesburg is probably tailing off now, and then it's moving out into the more rural areas of the country. So why does South Africa have so many cases? What have been the determinants? Is it climate? Is it population driven? Is it, what is it? So I think we are testing more than many other countries. We do have very strong laboratory services. So I think our high numbers are probably a reflection of the amount of testing that's been done. The highest incidences are in the metropolitan areas where there's a lot of overcrowding. There is probably low compliance with non-pharmaceutical interventions, and although masking is compulsory, distancing is not always done. A lot of people travel in public transport where there's no social distancing, often no masking. And I think it's this is a reflection. This is all being reflected in the high numbers. So it did coincide, the peaks did coincide with our winter months, but I think that's probably a reflection of how the outbreak has panned out rather than something that's particularly seasonal. So we're in more temperate, we are in the temperate areas. We do have subtropical areas. The rest of Africa has tropical areas, but it's difficult to say how this has affected the occurrence of COVID in the different countries. I think it's much more social determinants and an indication of testing. So South Africa is followed by Nigeria with 44,000 cases, Ghana, Algeria, Kenya, Ethiopia. These are all countries that have reasonable access to testing. And I think the numbers are probably a reflection of that. What about seasonality? Well, we were very concerned that COVID would coincide with our seasonal influenza season, which from a long-standing surveillance program, we know begins in the middle of May and goes on to August. And there was great concern that we would have two overlapping epidemics. So little surprising, but quite grateful that influenza season, in fact, has not occurred at all. It's a reflection probably of a surveillance program that is not functioning as well as usual, but we do have some testing done, and it shows that there's almost no influenza around. This is probably related to school closure. You know, children play a very important role in transmission of influenza to adults, related to the use of non-pharmaceutical interventions, masking and hand washing, which are also very important for reducing influenza, and probably this year a greater uptake in influenza vaccination, although the program is not very large. It was better than usual. I think people were afraid and made sure that if they could, they got vaccinated. So I think those are the reasons for the seasonal influenza not being part of our usual winter season. And then I think, you know, our other seasonal disease that we'll have to wait and see what happens is malaria. Malaria season generally starts beginning of September. Borders have been closed, but the prevention program hasn't been or may not be as active as previously because of lockdowns and difficult accesses, people not wanting to access clinics. So, you know, our normal seasonal disease may also not occur. Other viruses that usually occur in the winter season have also been shown to decrease, and I think it would be a similar reason to RSV and diarrheal illnesses, and I think rotavirus is one that we monitor, also less than previously, but again it may be treatment-seeking behaviors, people not accessing clinics for various reasons. So many people here have the idea that it's a winter disease. They're looking forward to the summer with lockdowns being released. I think many people are relaxing their guard, but I think the occurrence of COVID in our winter season is purely incidental. It's an indication of how the outbreak expanded during the season, and I think it's a coincidental thing, but we'll have to wait and see. So thank you very much.
Thank you. And I know that the Brahma is joining us. So Dr. Brahma Cohen, are you able to make opening remarks for 5 minutes? He's still not here.
Yeah.
Okay, good.
Yeah. I'm here. Thank you. And I'm sorry I just joined a few minutes ago because I was facing technical problems. So what can I say for those opening remarks? I will most focus on the title of the panel to make sure we all got a same understanding before moving forward when questions time will come. So we decided today to talk on risk communication and actionable informations. So one question one may ask is, what do we understand by risk communications? And what we can say while talking about communication. Of course, communication is quite clear for everyone. It's an information exchange, meaning that you have information givers and an information receiver. On who is the giver, who is the receiver. And generally, the receiver may be in the area of public health, the people at risk. But depending on also on what you are achieving, on what you want to achieve, the receiver can be someone on the way to reach the final people at risk. It may be, you may be doing a trainer a training of trainers. So the people you are training, the trainers are not the final people at risk, but they will use your information in order to reach the people at risk. So let's keep in mind that when we are talking about this communication, we have those two sides, the information givers and the information receiver. And how can we communicate? We can communicate by using some strategies. We can communicate verbally, as I'm talking with you right now. We can communicate non-verbally. It can be through hand gestures. It can be through facial sign. It can also be through written documents. And we also have a visual communication. It can be made of what people can see, what the final receiver can see. So communicating risk is using those strategies that can be verbal, that can be non-verbal, that can be visual to give information to a final receiver. And the channel can be a face-to-face channel. It can be an audio one. It can be a video one. And when we look today at those audio and video ones, due to the new development used in using NTICs, in using the new information technologies, the audio and video tools can be large. It can move from radio to TV and passing through internet tools, remote conference tools like this Zoom one we are using right now. So those channels can also be emails. We can also communicate through emails, through chat, through blogs, and all those scientific papers we are used to write, also through policy brief. So these are the main channels one can use while talking about communication. And what can be the actionable information? These are all those informations we can use to avoid the risk or to reduce the risk, depending on the risk, or to transfer it, or even to accept the risk. You may be facing some risk that you cannot face. So you may be obliged to accept it, to adapt to those risks. So those actionable information in communicating risk in the frame of COVID-19, we will have to look at them and see how they are being managed in our different settlements, in our different areas. And I can specifically contribute, taking the case of West Africa, mainly my home country, how we have been dealing with this in Cote d'Ivoire. And what can be then the contributors? Those contributors for communicating on risk can be the scientist community. It can be the decision makers themselves, who may get the information from some others who may be the scientific communities. It can be community leaders who can help also to communicate. It can also be communities themselves. As we know now, with those new technologies, with social medias, some communications are now going from communities to communities. And unfortunately, it's not always the good information that are given among communities by communities themselves. So that is showing the challenge we may be facing in communicating risk, mainly in the case of COVID-19 management. So these are the main introductory words I can give. And just to make how challenging it is, taking some few examples, specifically looking at how meteorological and climate parameters may influence the dynamic of the disease and how we can communicate on this in our settlement. From now, as Lucille was just saying, depending on the area, but when you take all those tropical countries in West Africa, since the outbreak started, we have been, most of us, all those countries on the tropic, we have been in one season. That was the long dry seasons. The countries that are, the cities and the regions that are on the coasts, on the tropics, they are mainly characterized by 4 seasons: a long dry season, a long rainy season, a small dry season, and a small rainy season. And since the pandemic started in West Africa, mainly in Cote d'Ivoire, it started during the dry long season. And this dry long season that starts from December and November, December to May, that was the period in which the outbreak started. And we just, from this long dry season, we just experienced the first long rainy season. So we experienced the first long, and this period of August, we are starting now the short dry season. Having said that, what we have been able to observe looking at the dynamic of the disease in Cote d'Ivoire is that during the long dry season, the transmission dynamic was the transmission was quite slow. It was really slow. And from the beginning, the first case we observed, it was in March, 5 March, I think. And from there to mid-May, the transmission was quite slow. And from mid-May, when we enter the long rainy season, we observe a higher transmission that evolved from mid-May to end July. And this is typically the long rainy season. And now we are starting with the short dry season, and we observe a decrease. So what can we learn from that right now? I think we can talk more
sorry
on it.
Sorry for interruption. And could you please leave the time? You know, we should leave some time for the discussions, for the questions.
I'm sorry. I did. When I did not know, I already reached the 5 minutes.
You know, very good idea. We know that. Very good idea. But do we have to limit the time? Otherwise, I'm not a good chair. You know.
Perfect. John.
Before I invite the next speaker, I just would like to mention that all the panelists should keep time. You know, we would like to listen to their questions, and you can have comments and on focus the questions. Okay. So next one will be Dr. Robert Branham. Please, 5 minutes or less than 5 minutes, much better.
There we go. Good morning, everybody. I hope everybody's having a great week so far. This has been a great conference. I want to start out with my opening comments on really 5 key points that really tie back to my eye poster that we put together. And I want to give a lot of credit up front to our 14th Weather Squadron. That's our climate services squadron in Asheville, North Carolina. They work with NCEI. They got a great partnership there with them. And, you know, I'll start out with my first point here. For us, we were asked questions by senior DoD leaders back in early March on 2 things. 1, environmental factors that would impact the COVID-19 virus, its transmission, and the life of the virus itself. The second part of that was what environmental events, i.e. extreme weather events, could potentially occur in the coming summer months that would impact a DoD response to to help work with the virus as well as continue its other normal operations, right? It's a very complex operation, so it's important to understand those two parts. From that, it's very, very important for us. We had to move at what we call the speed of relevance, all right? And that is, we've got to answer these questions now to the best of our ability, to look at what research is available out there, to really take a look at what type of research from an operational user perspective, from a non-medical community perspective of being able to apply that information to a product to answer these questions. So my first point here, and I think it's very important for this group to look at going forward, is having centralized locations for approved research as it relates to a pandemic and or infectious disease, to where an operational user can go in, get that information, review it, and be able to operationalize at a very fast speed to put into actionable products, and then communicate caveats of that. That's kind of a second point here of being able to communicate the caveats of uncertainty of that information to the users. And in our case, that's the Department of Defense. That's senior officers. That's 2, 3-star, 4-star generals that are asking for this information for planning purposes long term. So from that perspective, taking that too, and from a collaborative perspective, we need to continue to learn about these environmental impacts. There's been a lot of discussion already today about temperature, relative humidity, other parameters impacting the virus itself. I think a continued collaboration on that is important, and in documenting what we've learned so far, and then cross-collaborating, sharing that was an important aspect for us, for Air Force Weather, for our 14th Weather Squadron, myself, to be able to plug into groups like the USGCRP, Climate Change Human Health Group, the GeoHealth Community Group, being able to rely off those sources to take that information and as I said, once again, apply it to a product in a quick manner. The other aspect of this too, which is very important, we got to be able to link decision makers with information. A lot of information out there, a lot of discussions going on. We've been part of a number of these workshops going back to March. They've all been fabulous. I've learned, being an operational meteorologist, I've learned a lot about climate and health going through this, which has been tremendous. But I think going forward, a charge too is for us to be able to link our end users at the agency level with information, and do that in a very timely manner, right? The other part of that too is, as I said, to wrap up here, I think the collaboration is important. This forum we've had this week has been very beneficial to show the interest that's out there. I think we need to continue to have these groups to be able to bring forth the research and discuss it, bring forth research that's usable, right? And it's been validated so end users can take that, as I said, ultimately and provide it into actionable, useful information. So I'm excited to be a part of this workshop this week. I'm looking forward to hopefully more of these in the future. And I thank you all for this opening time.
Thank you. Now, let me invite Dr. Didish Dagra.
Hello, everyone. Good morning to my colleagues in the Americas, and good afternoon to those in Europe, and I guess good evening to all who are in this side of the world. I just want to briefly summarize my previous colleagues, particularly my colleague from South Africa, as like she had mentioned, that we have all we have a transitions in countries like India and South Africa, where we basically moved from a predominantly a rich sort of upper income population which was affected to a lower income, uh, most probably because the initial people who were affected, they were all the travelers, international travelers, and then it went down to the, then it went over into the general population, and through domestic assistance and so on into the community. Now, that was one aspect of it as far as the urban places went. And then what also happened was that India went into a shutdown, into a lockdown in March. And just after a sequence of those lockdowns, there was an unlock phase, so to say, where the population, the migrant population in these cities was allowed to go into the rural areas. And that led to this, all these cases now spreading all over the country. And that's, those cases continue to rise, as must be known to everyone here. India now has the third highest number of cases and fifth highest number of deaths in terms of absolute numbers. So, although handled very well initially, but somehow we seem to have really been losing the grip of late. And so now we are at this cusp. We don't know which way it will go. Now, to speak about, from here, to speak about the environmental component. And that is also a very interesting story, because the expectation was that the temperature would take care of the epidemic, which is something which ended up being wishful thinking in India as in other places. I won't want to go into details there. So since that was not the case, it was also very interesting as to why that was not the case. I mean, was there no effect? We could not extract the signal. We didn't have enough studies going on. What exactly happened? And so, although there is no clear, I can't say there are studies for this, but if you speak to the experts, they will tell you that many of the people who are there, at least in the upper income group, the way India lives now, you tend to stay in a constant environment. You go from your residences to from your residential establishment to your workplace to your mall. Anywhere you go, it's fairly constant in terms of the indoor environment, in terms of temperature, humidity, air pollution. So the air purifiers and so on. So this very important point emerges that should we really be looking very carefully now at the indoor environment and the micro environment that people stay in? It could be raining outside, people will not be out as such, right? So, I mean, we really need those sort of studies to be able to actually extract these associations. Considering when you have a outbreak like this, you also have very important factors like which are being discussed out here, like the population dynamics, the social distancing or the lack of it, the mask use or the lack of it. So all those factors are so predominant that the environmental factors, to again tease it out, is really unless you have these microenvironment studies with you have some devices that you are measuring 24-hour temperature and air pollution and so on, it would be very difficult to actually come to any clear conclusion. So that's where I'd like to end this part. There is one other part, Am I over, or is it, do I have a minute? Can I? So I'll just summarize one other aspect. And that is that regarding risk communication in India, one thing we had is nationwide phone messages after the lockdown in end of March. 1 billion plus phones we have in the country almost. And this basically used to give constant messages anytime you picked up the phone for cough, fever, breathlessness, your precautions, cough hygiene, hand hygiene, physical distancing, and also that one phone number which you need to contact. Eventually that also came in, something like the 9/11 of the US. So that's my summary for the opening remarks. Thank you very much for this opportunity.
Good, thank you, and thank you all for your wonderful ideas and comments. Now we come to the question time, and before my colleague Mike Shimamoto, we bring the question from audience. We have some time to from the science committee and some questions, and for you, especially, almost all the panelists mentioned about the information sources, especially how to inform the decision makers. What are the effective information sources? And you just give me a very brief answer. Which is the best one? Which is the most effective information sources? You don't have an answer. Yeah, I sense the Bob just mentioned that, right? You say you're trying to find the different various information sources and then inform the different agencies, right? How did you do that?
Well, I think from the Air Force perspective, I can actually start out here. We look at, I mean, when you're talking about, the pandemic here, you're kind of looking at S2S data, right? You're looking at predictive temperature, predictive humidity, predictive environmental impacts. So you go in, and in our case, we would leverage, data either from NOAA, National Weather Service, and NASA to be able to pull that data out for several months, and then take that, put it into a product that would be easy to understand for our folks that are out in the field, if that makes sense.
So why don't you rely on the information sources from CDC? In the United States, you have very powerful, influential CDC. Why you don't mention that?
Well, I was merely speaking more to actual climate data, forecasting of climate data specifically. We certainly look at what the CDC was posting on their website and all their data sources for what they're talking about. A lot of information there, of course, to sift through, and that's a challenge at times, right? Being able to figure out, okay, what is most important out of this.
Good. And I think the senior just mentioned that the social determinants play a more important role, and because you find there are cases in different climate zones, but the social behavior or social determinants are more important. How can you deal with that? How can you address the social and behaviors? That's the major issues.
So it's quite difficult. In South Africa, we've had to release our lockdowns because of the huge impact on economic conditions. And when people hear that, they think everything is okay. They stop watching the figures and the graphs going up. And I think they get the wrong message. So balancing those messages are very difficult. I think the other problem is the people are obsessed with numbers. So the mood of the nation kind of hangs on the number of cases every day that are positive. And I don't think that's a good measure of actually what is going on. So we have a lot of problems getting messages out about non-pharmaceutical interventions. There is no face to COVID for many. And young people particularly think, well, what's the problem? it's really an old person's disease or one part of the population, and trying to get that message out is difficult. And then battling social media with all lots of fake news is another challenge.
Good. I think need to just say emphasize, and India and Brazil and some other transiting economies. In your personal judgment or your personal opinion, does India or any other transiting economies really the different, or in taking the lockdown policies, or yeah, in making the prepared plan for that?
Sorry, could you repeat the question, please?
My question is that you just emphasize India is transition economy, right?
Right.
So in your judgment, transition economy is really different from other economies in terms of making the preparedness plan.
Right.
Is that true, or why you emphasize that?
Well, you see, it all comes down to that huge divide between those, who can, between that part of the society which can adapt and that which cannot. So, for example, to take it into another dimension, what is going to be the impact of school closure? So, school closures, many of the private schools, which also cater to a large number, I can't give you the exact percentage, but private schools, unlike in Europe and America, are much, much more common than in our part of the world. They are very common. So private school education is essentially uninterrupted, but the children in lower down, in the lower economic strata, they're having to struggle. So I was reading that even the second-hand shops have run out of mobile phones for these children because they need mobile phones now to access the classes. So suddenly, you cannot have millions of mobile phones available. So that's how, in a country like ours, with the numbers being so large, you have, one section which can adapt, which can work from home and do all that sort of thing. And then there's this huge section which, has no choice but to go and then leave the children totally unattended. And so there are lots of gaps that are there in the society. Now, why I'm emphasizing that this gaps, what it also leads to is the information asymmetry, right? So we were talking about all sorts of guidance for the mask, for example, but ultimately the WHO guidance, it was not known, but whatever it was, the WHO guidance came around to the fact that even simple cloth masks are fine. Now, if this message had gone earlier, so many people would have been protected. So if you give a message that you have very fancy protection which can only work, you will lose so much of the population. If you give simple message, it works.
Thank you. I think we got your point, right? In terms of risk communication, I think Bremer present the various tools. So in Africa, not only just from Cote d'Ivoire, your own country, but they're taking the whole Africa as which one is the most effective one for the communications of the risk?
Which one is the most effective? Effective as we would think, as we would like, as researchers, people coming with what we think is a good knowledge to circulate, or effective in the way of attending rapidly our audience, if I think the social medias, when we see how information are shared through social medias, we systematically need to encourage our decision makers and all communication leaders to try to have more control or more leadership in using those social media tools. Unfortunately, the ones who can, as soon as they wake up, use their mobile phone and start chatting, are people who have nothing to do.
It's good. I think it's very
you
clear
get my
now.
point. Yeah.
Almost all the panelists here did not mention any international collaborations. So we're here with the 2 minutes now, and do you have any idea about the role of international collaboration, and especially for the future, pharmaceutical development, or in the future for the precautionary measures? How can you, do you have any idea about that?
I think maybe, can I say something?
I think Lucilla is saying something that she's muted.
Okay.
Okay. So I'm not sure which collaboration you mean, but clearly it's critical. And it's critical for collaboration, not just north-south, but within the continent. And I think it's about access to interventions like vaccines and pharmaceuticals. That's particularly important. Otherwise, us in Africa are going to be left out. And I think collaboration is very important. And we should be leading on some of this.
Okay.
Fully agree. Fully agree.
Okay,
exactly.
Good.
Exactly.
And whom else?
That in the South Asian region, our Prime Minister has worked very hard with the 8 countries in the region, and that has really helped together to fight this pandemic.
Good, thank you. I have to leave 10 minutes to my colleague Mark, and who is going to bring the questions from the audience, and you may answer the questions from the audience. Mark, please.
Great. Hi, everyone. So there's been, again, a very robust discussion on the chat, ranging from population dynamics, political leadership, combating stressors with extreme events or other concurrent infectious disease risks. But one area that was discussed a little more deeply was this notion of excess deaths, especially where low testing might take place, and ascertaining the true impact of COVID-19 in death reporting. There was a discussion that what is the true proportion of COVID-19 deaths versus those that may relate to people who have chronic or unrelated acute conditions, who might not be seeking treatment because they themselves feel at risk of catching COVID. I thought maybe we can start with a reflection from Lucille, and then I'd open up to others.
He's muted.
Lucille, you might be muted.
Okay, you can hear me now. I think it's important, if you want to collect statistics, to look at hospitalized patients, because there you can see the morbidity, mortality related to COVID, rather than just using up all your tests in the community to see the extent and daily numbers. So I think focus on hospitalized patients, very good. It's very difficult to tease out in many cases, is it a COVID death? How much of the comorbidities contributed? But I think there's a very clear WHO definition for surveillance purposes. Anyone with a positive COVID test, or in the eyes of the physician looks like COVID, it gets put down as a COVID death, and the other conditions which are often present are noted as a secondary cause. The excess deaths, patients who die out of hospital, are a major issue. Some of them are COVID, they die at home, they die in chronic care centers, they die from non-communicable and other communicable diseases because programs have collapsed for both of these. People don't access care, don't access medication because of the fear of COVID. So, you know, I think it's a big challenge. I think I'll stop there. But it's important to measure the impact of COVID if you want to manage it.
Great point. Any other comments?
So what I would like to mention is that in some studies, they are not really, I would not say formal studies, but they are more like exercises that have been conducted by journalists. What they've done actually is gone to graveyards or funeral sites, and they've gone and kind of checked what is the mortality for this year versus last year, and so that's definitely the excess mortality. And then they check against the hospitals, and you can get the difference, in which you may take as a sort of correction factor or whatever. But yes, that is really important, because if you don't do that, then you will really misinterpret your analysis. Where in countries like India, where reporting is a huge issue, particularly in something like COVID, where in the hospitals don't necessarily encourage the cases to be to be seen as COVID positive cases, whatever, want to just hide it under the carpet. That could happen.
Great, and I thought I'd ask one more kind of broad question for the full committee, just to kind of take a step back, and when you kind of reflect on what you've learned so far in these first 6 months of the COVID-19 pandemic, and relating to preparedness, risk assessment, and environmental influences. Moving forward, given that you guys have such rich on-the-ground perspectives, what capabilities would put your institute or organization or communities you work with in a better position to disseminate actionable information for future pandemics, either a wave 2 of this current one or a non-related but still as impactful pandemic?
Yeah, I think I can speak briefly to that. From an environmental driver perspective, having information quickly that's been approved, and I say approved, peer-reviewed, and assessed as being valid research that can be applied to products in a centralized location. And it kind of goes back to my points I had from the opening comments on we need to be able to to move at time relevance to be able to provide information to answer questions.
And I can add very, very briefly that based on experience in some of our West African countries, we also still have challenges in leadership among all actors involved in risk communication, risk assessment firstly, and risk communication. When you take the case of some countries, unless of working with national services in charge of meteorological data, some of those countries are mainly working with some people coming from universities and who may need to make the decision to go back to national services in charge of collecting meteorological data. It would have been more easier to work directly to those services, but it leads to a question of leadership, and how to move forward with this is also a challenging issue. I think we should face in designing more risk assessment and risk communication strategy.
So just in line with that, I'd like to add that, for example, in India, we have the NCDC, which is equivalent to the CDC. We have, on a real-time basis, the data now being collected on more than 30 disease conditions. We have our Indian Meteorology Department, which can collect all the data for meteorology. But the problem is that the two departments have not yet aligned. And so we don't have the data sets and the time series linked. So that remains the challenge. And the second point I want to make is that we must be also able to see for extreme temperatures, for our floods, and for cyclones, for example. What is it that what those extreme events and how they are linked to the COVID-19 outbreaks or excess cases? What sort of link is emerging? We don't have that analysis done so far. So I think those are very interesting aspects which need urgent consideration.
And I would say you need flexible, nimble, quick, robust hospital surveillance systems that get ahead of the curve. And within 4 weeks of us starting a Sentinel hospital system, we were up and running. And the usual data systems in the country are still way behind.
Great. Thank you for your contributions, and I'll hand it back over, and then we can close out.
Good, thank you, Mark. And also thank all the panelists for their thoughtful ideas and comments, and also thank the other and audience for your participation. We have wonderful discussions. And I know because of time limitation, we couldn't discuss all in detail. And I would like to end the panel discussion. All the participants are welcome to join the breakout group discussions after the panel session. Thank you for your participation.
Thank you, Yang Long. And we will now take just a 5-minute break before the breakout sessions start.